Thank you, and good morning. For full transparency, the glitches being referenced, I feel like, are all on my side. And just to let you know where things sit right now, I can't see anything but my slideshow. So if there is an
That's all we
issue,
need to, I think that's all we need to see right now. So,
okay, I didn't know if I was supposed to be seeing your face or other faces or.
nope, we're going to look at your slideshow.
Okay, very good. So when we get to the video, we'll navigate that hurdle and see how it goes, but we're a little ways from there. So good morning. Welcome to the session. It's an honor to have the opportunity to present at the conference. As mentioned, my name is Ken Roberts. I am the Chief Clinical Officer at NuWay. NuWay, if you are not familiar, is a nonprofit that was founded in 1966 with a mission to provide recovery in supportive environments. As we celebrate our 55th birthday, that mission now encompasses 13 programs in 17 different geographic areas around the state of Minnesota. We provide licensed co-occurring residential and outpatient services covering ASAM levels 3.1, 2.1, and 1.0. And we're participants in the state's 1115 waiver project. So my email is there on the screen. Please feel free to contact me at any time regarding questions from this presentation or anything else. Okay, so some basic objectives that we want to achieve with the presentation this morning. We want to define this new idea of pandemic trauma and stress experience. We want to be sure that we differentiate how that is different from clinical post-traumatic stress disorder or PTSD. And then we want to take a look at some of the evidence-based care interventions to treat these conditions at individual, group, and agency levels. So some of you may recognize this famous quote by early 19th century philosopher George Santayana. It's been frequently referenced and paraphrased by statesmen and leaders, including Edmund Burke and Winston Churchill. I'm using it here in the context of the shared experience we've all been living through for the past 18 or more months of the COVID pandemic. I really believe that applying the knowledge and experience that we've gained during this time is going to be critical in supporting positive outcomes for clients dealing with co-occurring addictive and mental health disorders as we move forward, and hopefully at some point through the pandemic. So let's start with some examples that we already know about. As we're going to explore further on in the talk, the term trauma can be applied to a broad range of experiences that impact individuals in very different ways. However, there are also very well-established data patterns that offer us really useful learning applicable to our current circumstances. I did try and review the top 10 worst epidemics or pandemics in history, but unfortunately the records from the most significant, which was the Black Death in the 1300s, are a little spotty. Even the most relatable past events in our US history, flu epidemics in the early 1900s and 1960s, lack some of the useful population data on addiction and mental health occurrences. But there are some recent community-based traumas that provide really salient parallels, and that's what you're looking here on the screen. To the left, of course, September 11th, the 9/11 terrorist attacks in 2001. And on the right, Hurricane Katrina, which occurred in 2005. Very simply put, large-scale traumatic events have significant negative impact on addiction, and mental health patterns for our population. And I'll observe the trends for these two events with the recognition that similar outcomes occur from a range of occurrences like these, such as wildfires, mass shootings, and other natural disasters. So here is some of that data. On the left, post 9/11, we see nearly double the rates of depression and PTSD, as well as a spike in substance use for New Yorkers following that event. And then on the right, you can see similar mental health trends present for those who experienced Hurricane Katrina. What's key to note in both of these events is that these trends were identified not just immediately following, so the year after these events, but that this pattern continued to increase actually for another 2 to 3 years beyond the occurrences. And that pattern is consistent for that range of community-based traumas that I referenced. So why is that dynamic important? Well, it's actually critical to recognize in terms of both the scope and the duration that we have been experiencing with the COVID pandemic when we think about long-term impacts. Although there have been recently some potentially positive signs for the dissipation of this wave, it's an experience that is impacting us globally and has been going on for nearly 2 years without a foreseeable definitive resolution. So I'm going to ask you to travel back in time for a moment to the early months of 2020. It seems really long ago now to me. I think at that point, most of us in Minnesota were starting to think about spring, things like how the twins were going to do, trips to the cabin, and all of the warm, fuzzy thoughts that we usually tend to have at that time of year. But in the span of a few short weeks, our worlds, both personally and professionally, really started turning upside down. Since then, we've been on a roller coaster ride that has included the promise of vaccine relief and lessening restrictions, but those continue to be undercut by new waves, the Delta variants. Here we are 18 months later in a world that's been profoundly changed by what's likely to be a generational event. The acceleration of that initial timeline was so rapid and disorienting. As we consider the potential long-term impacts of the pandemic, we have to recognize that versions of the individual challenges each of us have faced are literally occupying the consciousness of billions of people around the world. And so in interactive settings, I've asked people to raise their hands when I ask these questions. I'll ask you out in the virtual world to just, think about how some of these words resonate and what your experience was. For me personally, I know that fear and uncertainty were pretty prevalent. That anxiety has been a pretty consistent companion during the duration of this event. And at times that I've been pretty angry or frustrated. So I'm guessing some of those words or concepts resonates with you out there as well. And so, think about that for yourself, and then also really think about how that plays out in terms of the people on your team, the folks that live in your household, in your town or city, in your county, across the state of Minnesota, across the country, around the world, so on and so forth. The paradox of this pandemic trauma experience is really an important one to recognize and hold in balance. On the one hand, there are these common types of feelings and experiences that we can all relate to and that have become common themes of our daily conversations. Yet on the other, there's myriad unique and intensely personal stories that are often born in silence and solitude. The wellness wheel that I've put up offers a useful categorical structure to consider how any type of trauma can impact our functionality. And of course, in the case of this shared COVID experience, we can easily identify shared patterns such as social deficits, being in lockdown for a protracted period of time certainly took a toll in that regard. Certainly the physical safety concerns inherent in facing a highly contagious disease is something that we've all shared. Yet simultaneously, there's broad ranges of perhaps occupational or emotional impacts that are very distinct and unique for each of us. And, we can kind of extrapolate that across all of these categories. So again, I'll ask you to just look at those categories and think for a moment to yourself, where and how have I been impacted in a functional way in terms of what I've endured during this pandemic? That may be very similar to some people, and distinctly different from others. And that's really important as we consider pandemic trauma and also in any conceptualization of trauma, as we will see. So part of the enduring strain of the pandemic has been the uncertainty of its actual end, leading to chronic stress and erosion of even our most healthy coping strategies. As we look at different trajectories worldwide, we can chart the ebbs and flows of both societal and personal emotion. At present, I would have said we're seeing cautiously optimistic signs of improvement at the national level. But then when you turn on the news here in the state of Minnesota, we are trending in a distinctly negative direction. And in fact, as of last night, have some of the worst numbers in the country as we head into the winter months, prolonged indoor time, cold flu season, etc. And so, this prolonged period of instability has really set the stage for a potential behavioral health crisis if we're not actually already in one. And again, when we think about those patterns that I highlighted with 9/11 or Katrina, of this continuing not just in the year after pandemic, but for a protracted 2, 3, 4 year periods, it starts to become a little bit incomprehensible to think about the potential magnitude of what we may be facing. And so it's going to be critical that we as a field continue to innovate and be prepared to meet those care needs in a meaningful way. So this composite really highlights across a range of categories that those needs began to be evidenced early on in the pandemic and have continued to accelerate across its span right here to the present. Anxiety, depression, trauma stressor disorders, substance use, self-harm, overdose, all grim indicators reflecting the needs and deficits we're seeing as professionals, and that will continue to add to that deaths of despair category as part of COVID fatalities if we can't expand access and improve outcomes. And of course, for our purposes of this conference here today, you're probably the experts out there listening in terms of problem gambling and how that specifically has been impacted during the pandemic. But my guess would be that all of these pressures have created the same sort of trajectory in terms of increase and severity. I think the middle graph here is really important in terms of summarizing the challenges ahead. And that is in terms of unmet mental health need. So we know that that has increased dramatically. And just this morning, before coming to deliver this, I heard a piece on NPR talking about wait times and service access. It was focused on the state of California, but it's consistent across the United States in terms of just not being able to provide individuals access to the care that they need. And that is further complicated by the fact that even though they identify they need it, that many people are not actually willing to engage with it at this time for a variety of reasons related to the pandemic. So how we will address those needs is going to, of course, continue to be influenced and complicated by our overall societal progress. The graphs that I've included on the right are really important just in terms of thinking about what may be ahead. And what those represent is a series of models or projections dependent on engagement with vaccine uptake. And so you can see that, there is the potential based on some of these factors for this to be with us over a pretty long range of time. I know that's something that gives me pause and certainly it is difficult to conceptualize because we're all worn down and weary already, but I think it's important that we keep that as part of our perspective moving forward. And just to truly put those concerns in perspective, of course, we need to remember that all of this has been layered onto the conditions that existed pre-pandemic. In case anyone has forgotten, and I doubt that you have, we weren't doing all that well then either. And so as these statistics remind us, coming into the pandemic, we already had identified high rates of untreated co-occurring concerns. We're in the midst of an opioid epidemic, and none of those concerns abated because COVID arrived. To the contrary, as we've identified, the pandemic has significantly enhanced the level of client need while simultaneously taxing our access and research capability even further. It's really a perfect storm, leaving those that we serve more at risk and more vulnerable than they've ever been. So the overall pandemic paradigm we've reviewed thus far encompasses some pretty broad considerations for our fields that are going to require thoughtful, innovative, and very collaborative solution focuses at a multitude of levels. An example, our rapid pivot to telehealth services has certainly demonstrated that we do have the capacity for dynamic adjustment, and more of that inspired attitude is really going to be called on from all of us. A key part of that work is going to entail accurate analysis of both our clients' presenting and underlying concerns in concert with appropriate evidence-based interventions. For our focus today, to better understand and address pandemic stress and trauma, I want to first consider the foundational role of trauma in so many of our client presentations. I think, unfortunately, we're all too aware of how frequently childhood or developmental trauma has been a part of those stories. Despite its discouraging revelations, the longitudinal ACEs research, which was begun by Kaiser back in 1995, has really provided us invaluable insight into the prevalence and long-term impacts of abuse, neglect, and household dysfunction experienced before the age of 18. Unhappily, ACE prevalence is far higher than we would hope. The data indicates that approximately 10% of individuals experience at least 3 adverse childhood experiences, and that the number reporting 4 or more is even higher at nearly 13%. I think those numbers are significant on several levels. Firstly, they're almost identically aligned with the number of United States adults who are experiencing co-occurring substance use and mental health concerns. And that dynamic underscores the second factor of note, which is displayed here in terms of the lethal legacy of childhood abuse correlated to a broad range of wellness areas beyond the specifics of addiction or mental health that are present in our clients. More specifically, for individuals reporting 3 or more adverse childhood experiences, there's what is called a graded dose response potentiating effect that significantly raises their risk factors for all of the categories that you can see in this array. ACE conceptualization has also now been extended to consider historical, generational, cultural, and socioeconomic factors. And if we look at our circumstances in the pandemic specifically, we know that extended enforced household isolation and other disproportionate pandemic stressors are undoubtedly creating the potential for increased ACE occurrence. Also on NPR this morning, I was reminded that the rates of domestic violence have soared during the pandemic, and that's consistent with this. At our agency, we screen all of our clients for ACEs on admission, and our data has verified that over 30% of our clients are reporting a clinically diagnosed trauma or stressor disorder, and it's very common for us to see ACE scores well above 4 when they're doing that initial screening. And of course, we want to recognize that those are individuals who are identifying or reporting that diagnosis, and we know that frequently that's something that they're either not fully aware of or are unwilling to share during the treatment episode. So Dr. Gabor Mate does wonderful work in this area. And this is a quote from his work: "Trauma is not what happens to you. It's what happens inside of you as a result of what happens. Wherever it begins, trauma is an event-based occurrence that overwhelms an individual's coping capacity." And I think it's really important that we understand it's not about the event itself, but it's the way that it is experienced by the individual. So whether we're considering traditional clinical trauma stressor disorders or this new conceptualization of pandemic trauma and stress experience that we'll review momentarily, it's critical to look at that bottom line individual experience as the key consideration in terms of what happens next, because it is the experience at the individual level that ultimately determines whether it is traumatic for the person experiencing it. For example, if all of us were to experience a car crash event, my experience of that crash might affect me in a number of adverse ways that impacted my functionality. I might develop anxiety. I might not be able to get in my car. I might start to isolate, so on and so forth. While conversely, others of you might be able to process and move on from that with minimal or no impact on your daily or long-term functionality. And so that same scenario is true for how each of us has, is, and will continue to experience this COVID pandemic. So thankfully, that latter scenario that I just described, having the resilience to rebound and move on, is the more common. Although ongoing exposure to the population that we're serving might skew our experience or perception to some degree because trauma is so prevalent among that group. The reality is that many of us have this array of resiliency or protective factors that do allow us to weather the storms of adversity that we face and move on from them without significant impact. And so as we think about interventions and care models, it's really critical that we be looking at strategies to promote resilience among those we're serving and to help develop and reinforce the protective factors in their lives to support their recovery process. So here is specific data on the prevalence of PTSD. The number of adults who experience a traumatic event is disturbingly high. But it is contrasted with the differential between those who actually reach threshold for a diagnosable PTSD condition. So in terms of that high number of individuals experiencing a traumatic event, unfortunately, women are twice as likely to be in that category of men. And we should note that the data we're looking at here is not taking into account adolescents experiencing ACEs. So we know that that number is around 25%. In all categories, these numbers are strongly correlated with the development of a substance use or behavioral addiction. And so that really frames some of the client profile that we are seeing on a consistent basis. As we review the symptom presentation for clinical trauma, specifically PTSD, and contrast that with pandemic trauma and stress experience, continue to keep in mind the continuum of events that might constitute a traumatic experience, with a reminder that whatever level of exposure occurs, it's that individual experience that's really going to dictate the outcome. The core effects or symptoms of clinical PTSD fall into three primary categories. As you'll note from the Sancho language here, those symptoms must significantly impact functionality. On the left, re-experience often includes intrusive, repetitive, unwanted memories of the traumatic event or events, and can include flashbacks or nightmares. On the right, hypervigilance, which is also frequently referred to as increased arousal or hyperarousal, connotes the damaging and ultimately unsustainable levels of being on high alert in an attempt to protect oneself from the past event recurring. Those symptoms can include heightened startle response, tenseness, irrational anger and outbursts, and sleep difficulty. In the center, avoidance is what I consider the hallmark of PTSD. And it's also often the most insidious aspect to ferret out, because it can bleed into a range of seemingly benign behaviors that disguise the manner in which they limit functionality. Obvious examples would include attempts to avoid people, places, or things that remind one of the trauma, and may also present an emotional numbness or depressive type symptoms. Of course, for so many of the clients that we use, that we serve, substance use or addictive behavior can be one of the foremost avoidance and strategies that is employed. Aligned with that understanding of protective factors and the concepts of resilience and natural recovery, it's important to accurately confirm the symptom duration in terms of any formal diagnosis and also the requisite clinical interventions. So persistence of symptoms resulting in functional impairment for more than a month is the key threshold that's going to differentiate a longer term PTSD diagnosis from straight acute stress disorder. And so again, if we think about the example I cited of being in a car crash, it would be very common to have some lingering impact or effects for several weeks after that, to be shaken up, so to speak. But if those symptoms were persisting and impacting functionality into the longer term beyond a month, that's when we'd start to think more about PTSD as the presenting concern. So here on your screen is the full array of formal DSM-5 PTSD criteria, which we've touched on already. One aspect bearing some additional commentary, I think, is the impact of trauma on thinking or cognition, the negative view of oneself, the interpretation of the world as an unsafe place, and inaccurate self-blame attribution are all really common presentation components that need to be evaluated and addressed as part of treatment. Of course, for those of us working in a primary substance use disorder setting, it's also necessary to ensure that a client has achieved enough stability to rule out substance use as part of the symptom presentation before a formal diagnosis would be issued. Lastly, during evaluation, it's also really important to consider complexity. For so many of the clients presenting in our settings, ACE history, prolonged or repeated patterns of trauma exposure are going to likely result in broader symptom profiles and chronicity requiring a greater range and duration of targeted interventions. And so this distinction, as you can see, of simple versus complex PTSD is really predicated on, that underlying event. And so for a single standalone event, such as that car crash that I identified, that would be what we would term simple PTSD. And just for clarity, I don't consider any PTSD simple in the way that it affects those experiencing it. But in that scenario, treatment can be oftentimes more straightforward and of shorter duration. Whereas for clients who have experienced prolonged or repeated trauma, that there's going to be a broader tangle of considerations that need to go into therapeutic intervention. So here's a quick visual, which just summarizes everything we've been talking about. And so, think of some of the clients that you serve, and likely you have seen or heard reports of this range of symptom presentation. I think it's really important to keep this in mind in terms of, what it looks like, because oftentimes it means we're seeing our clients when they're not at their best, and that it's really important, and I'll continue to emphasize this, to be thinking about what is going on behind or below what's being presented to us. What is driving that, and what do we need to do in considering that as part of our care. So in considering treatment strategies for clients experiencing co-occurring conditions that include trauma, it's really important to recognize that in many cases, the use of substances or the employment of addictive behavior is really the only coping strategy that has offered any sort of effective relief from the pain and symptoms of the trauma that they've experienced. Referring to Mattei again, it's impossible to understand addiction without asking what relief the addict finds or hopes to find in the drug or the addictive behavior. And so, he posits that we can't be looking at just the addiction, but seeking to understand what is the pain that is underneath that. That conceptualization provides an excellent segue to considering how the pandemic may be expanding our conceptualization of traumatic exposure and acting as a potentially amplifying risk factor for our already vulnerable clients experiencing co-occurring substance use disorder, addictive behaviors, and a trauma stressor disorder. So this conceptualization by the American Psychoanalytic Association is new and continues to evolve. And it's really looking at the way that we as individuals and a society have had to adapt to a prolonged pandemic way of life, filled with all of those words I mentioned earlier: uncertainty, fear, and loss, which of course can increase our experiences of depression, anxiety, sadness, loneliness, relational conflict, substance abuse or misuse, and violence. And just as we've identified already with clinical trauma, that those responses are very individual and come in a broad range or array. What's important to really keep in perspective today is that PTSD is not a diagnosis or disorder. And, the APA is really looking at it as a shared community phenomenon around how we've adapted. And I think this is the key part for me, that all of us are experiencing some level of PTSD. So why is that important? Well, it's important because it means that, it's being experienced on both sides of the coin, not only by the clients who are coming into the care, but by us as the caregivers, and that's going to have an impact on some of our ability to be able to deliver that care effectively. So this conceptualization, I think, is very helpful in terms of giving us a broader framework to distinguish what is likely to be a very common presentation, and being aware of what may be behind it without leaping to conclusions around a formal clinical diagnosis. In terms of stigma regarding terms or labels, always important to make sure that we are erring on the side of caution and not adding an unwarranted diagnosis to what is likely already a challenging sense of self for many of the individuals we're serving. And that can be a little bit difficult in these circumstances. So as we look at this side-by-side presentation, you can see that there are numerous crossovers. I think the most salient difference and thing to bear in mind is really pinpointing what the target trauma is. For a formal PTSD diagnosis, the trauma experience must represent intense fear and threat of bodily injury or death for the individual who's experienced. So that occurrence might indeed be present as part of what that individual has experienced during the pandemic. And it's really important to recognize that PTSD may be precipitating or leading to PTSD, but that PTSD is not automatically PTSD. So here's a little more depth to consider in terms of some of those unique experiences born out of the pandemic. And you can see on the left, some of those considerations for an individual. Fear of dying alone, fear of infecting loved ones. Whereas on the right, we've been able to observe how this is played out in our community. A lot of bad behavior, a lot of polarization has come with the pandemic, causing all kinds of cultural disruptions. But it also highlights that there are parts of the pandemic that have actually resulted in positive aspects from a societal perspective. And so that's useful to keep in mind as well. Generally speaking, in this stage of what PTSD is, these factors are really being identified on a much broader spectrum than clinical PTSD, and appear more broadly transferable from both an individual and community perspective. And so want to keep that in mind as we're looking at individual client presentation. And as I mentioned just a moment ago, if we're all experiencing pandemic trauma in some way, it means we're simultaneously dealing with it and treating it. And that means that we as professionals are going to be subject to the same identified vulnerabilities that we already knew about in terms of working with trauma, but at higher levels than we have experienced in the past. And so the commitment to self-care at an individual, at a team, at an agency level is going to be critical in terms of maintaining sustainability to provide care. We're already seeing workforce deficits that project into really challenging trends and that are likely to negatively impact service access in a future where we're anticipating significantly increased needs. Our field was already one where turnover was a fairly common experience. You can see some of the figures here. Almost a third of counselors, almost a quarter of supervisors, and a particular level of vulnerability for individuals in the field who may be in personal recovery if they are not tending to that individual side of things, that the stress of the work that's being done can put them at higher risk. So all of this, really important in conceptualizing some of those broader, longer term challenges that we're likely to face. And here's another quote that I think gets at that explicitly. If we do not learn from history, we shall be compelled to relive it. True. But if we do not change the future, we shall be compelled to endure it, and that could be worse. Toffler's amplification on those previous words of Santayana, it's a clear call for action in our fields on a number of fronts, I believe. Okay, so we've spent a long time talking about the problem. Let's switch our lens to a solution focus if we can. Some of the concepts and discussions in these broader categories are maybe beyond the scope of our focus today. But I do encourage us to keep them in mind along with the daily work that we do. But let's turn our attention specifically to how we can best treat co-occurring trauma, including that enhanced layer of potential PTSD. So if there is such thing as good news when considering the dark topic of trauma, it's that the concepts and evidence base for effective interventions are applicable regardless of the label of the presenting concern. In short, the negative behaviors and cognition associated with any type of trauma are responsive to targeted care concepts, and we will look at those. One of the key pieces that ties together trauma and substance use addictive behavior is the sense of isolation that often entails. So in my next slide, I'm going to hopefully show you a brief video which will kind of highlight that sense of isolation. We'll use that as a jumping off point to be able to look at some of those interventions. So let's see.
Ready? 3, 2, 1, action. 125 decibels right there. We're gonna have to clean this up.
I just walk up, introduce yourself maybe one time.
Okay, that's fine. Cool. And then when they look around, you guys are completely normal, like nothing happened.
Hey, good morning.
Hey, how are you?
Good, how are you?
Good. Can I have a hot chocolate?
So you just want, do you want a double espresso or a single?
Double is fine.
Okay,
You got whole milk?
I do.
Let's do it.
Okay, do you want a medium, large?
No medium.
Medium, and do you want that for here?
Yes, please.
All right. Let's get this going for you. Do you want that for here to go?
For here is fine.
Okay.
All right, get ready. 3, 2.
Okay.
Did you hear that?
Hear what?
That explosion.
No. Just making some coffee. What's the weather like outside today?
Freezing.
Is it? Yeah, I'm not a big fan of the cold. That's why I live here.
He's gonna shake you. Get ready for dog barks.
I don't know why I do it, but sometimes I just have to shake the beans too. Thank you very much.
What was that?
What was what? You guys enjoy the day?
Thank you.
Get out of here.
I don't know.
Hey guys, come on over here. We've got cameras right here, and we've got a camera right here, a camera back here, a camera right here, one right back here, one right up there. And if you don't mind, I'm gonna take you in the back here. Just go on through.
Thank you.
Oh, you okay? What happened there? I'm veering you onto the one coffee I know how to make with my 4 hours of training as a barista. So, did you notice at all that no one else was reacting to the noise? How'd that kind of make you feel?
Alone?
I just wanted somebody else to be on the same wavelength as me because I felt like I was the outcast and nothing happened. Nobody looked around and looked at me and nothing.
How'd that make you feel?
Isolated?
What would you think if you had to deal with the same things you dealt with today, every day?
That would be debilitating. It would be scary to even leave my house because you don't know when or what to expect from day-to-day life.
That's what 24 million U.S. citizens deal with on a daily basis. It's not mostly veterans.
Really?
A lot of people go through a lot of difficulties with post-traumatic stress. Did you hear the dog bark? Did you hear the car wreck?
I did, yeah.
I was a Green Beret. I lost 5 friends in a 6-month period. You know, it's hard. It's just a memory or emotional attachment to something that they need to work through.
It's jarring. And not just my personal, but to hear the numbers and to hear your story a little bit and know that people are suffering in silence. It's always been the sort of thing where you don't really talk about it, and that's not right, you know, if we're gonna heal, you know?
Chris, come here, brother. Get another hug from you. Thanks, man.
Thank you.
Yeah, man. I really do.
Right on, man. Yeah, nice to meet you.
Nice to meet you as well.
Yeah.
Thank you for doing
Yeah,
this.
of course. Thank you.
So that video is called The Social Experiment, and it was created by an organization that promotes the dissemination of accelerated resolution therapy and training. And we'll talk a little bit more about that. I've probably seen that video 100 or more times now. And if you can't tell from my voice, it still has a pretty profound impact on me. The first point of conceptualization that I think about in terms of addressing trauma is attempting to mitigate that sense of isolation and stigma. So another field expert, Johan Hari, I think speaks really eloquently to this topic. He says the opposite of addiction is human connection, and that pain is the fuel for addiction, that people are addicted because they're trying to avoid their deep internal pain. Trauma sufferers experience pain that they attempt to mitigate through substance use and addictive behavior, and that creates a deep disconnection, which is really important to address, and community and connection is the antidote to that. So that's certainly a formulation that's important to me, but it's not just theoretical. It is backed by data. Some of you may be familiar with Dr. Bruce Alexander's rat part experiment. If you're not, in brief, Alexander created two environments. Those are highlighted on the screen. In the environment on the left, we can see a lone rat with unlimited access to water and morphine. No amenities, no interactions, isolated. Those rats frequently accessed the morphine, and the mortality rates in that test group was very high. On the right, another group of rats were provided with rat amenities, balls to play with, tubes to run around with, but most importantly, the company of other rats in Rat Park. These rats also had unlimited access to water and morphine, but they rarely accessed the morphine and experienced minimal mortality. Very strong evidence for the protective factor of community. And again, Matei, safety isn't the absence of threat, it's the presence of connection. Creating a safe environment is key to a sense of connection. Connection alone isn't going to magically ameliorate the problem, but it provides the foundation for healing to occur. That's the care environment that we want to strive for. So how do we accomplish that aim? Well, whether it's from an individual, a team, or an organizational perspective, environmental safety really aligns with the principles of trauma-informed care that you can see here on the screen. So that begins with simply realizing the impact and prevalence of trauma, being able to recognize how it is presenting, and then responding in whatever way is appropriate through education, training, policy, procedure, and practice in your setting to be able to treat it effectively and, of course, prevent the cycle from recurring. So if we view it through a little different graphical presentation, we can see the way that a trauma-informed care perspective might be developed in the practice setting. As we've emphasized in the conceptualization of trauma itself, the trauma-informed environment needs to be highly individualized to the site or team providing care and to the clientele being served, while adhering foundationally to the 4 R's that we just reviewed. So again, you know, as you are looking at this in your individual setting, think about where you are practicing and look at some of those key bullets in terms of creating safe context, restoring power, building self-worth, and think about, you know, how does that show up in my setting? What is a point or area where we might want to consider how we could do better? Just like any environment, it's not a static endeavor. There is always going to be a fluidity, and so continuing to evaluate how we're doing in this area and making adjustments as we go is very important. Now, we hear the term trauma-informed pretty frequently, and true achievement of that status is really a phased process that requires leadership endorsement and staff engagement at all levels. It's important, as you consider your own environment, to be really honest and objective in your evaluation. The graphic I've got on screen here offers a really useful overview for evaluating the objectives that delineate progress in a trauma-informed care environment. And you can see it's a continuum. And if you look at the different markers and tasks that might relate to each phase in that continuum, it provides a useful tool in looking at your setting, team, agency, etc. There are a number of useful tools specifically for this purpose, as well as a number of resources if you're interested in accessing those. And there's a resource slide at the end of the presentation, which has some information in that regard. And I want to emphasize that that support should extend into the community as well. The list on the screen probably looks pretty familiar, but think about how well are any of these resources truly being utilized in your care model or setting. What's not on there that should be? What else could be included? Commitment to a trauma-informed setting and an integrated community-based focus really are going to provide that foundational holding environment that supports client safety and builds trust that will allow for the clinical interventions that we want to review next. From a strictly clinical perspective, a balanced, resilience-focused approach that both assists with symptom management and addresses cognition, including traumatic memory, really offers the best prospects for a sustained long-term recovery. As I've stated repeatedly, trauma experience is a highly individualized event, and treatment interventions should mirror that in a similar person-centered approach, even within the structure of manualized curriculum or therapy protocols. Let's start with medication. There's no standalone medication intervention for PTSD, but there are a range of options that demonstrate efficacy for trauma-based symptoms, including anxiety, depression, and nightmares. Despite frequent endorsement by many of our substance use disorder clients, benzodiazepines should not be considered in that category, due not only to addictive potential, but their perpetuation of avoidant behavior, which is key in trying to develop a sound recovery protocol for trauma sufferers. MDMA and other psychedelic therapies have gained some notice in recent years, but I would consider those still more experimental than established. In all cases, medication should really be considered an adjunct to, but not a replacement for trauma-focused therapy. Curriculum is an important consideration as well. There are numerous established, effective trauma-focused curriculum. You may recognize several, if not all of the titles pictured here on the screen. Seeking Safety has been a long-term treatment staple, and Covington's work is popular and well-known. The real value in utilizing a curriculum component is that it allows clients to immediately begin receiving education about their trauma and developing coping skills for stability in a uniform, community-focused manner. Curriculum integration is an effective tool for helping alleviate isolation and helping remind clients they're not alone, because it is able to be delivered in a group format. Curriculum work really helps set the stage for, but is not a substitute for trauma-focused therapy. Any group work with any of these formats should not include processing of individual trauma experiences and memories beyond general terms. So these are great as foundational and timely interventions. That idea about skill building, being able to manage better on a daily basis, is really going to be pragmatic in then helping prepare clients to do some of that deeper work that needs to occur in individual therapy protocols. My agency recently began using the BRIGHT curriculum, which stands for Building Resilience for Individuals Through Trauma Education. This was developed by New York psychologist and SAMHSA consultant Anthony Salerno. You can learn more about this particular curriculum at the link that I've included. I'm singling it out in the talk today just to briefly highlight that this is a standalone modular workbook format and that it features a strength-based resiliency format. That means that clients can plug into this at any point as they enter the treatment milieu, and that it's really focusing on some of those key factors that we identified earlier in the presentation today regarding resilience. So taking that what is strong versus what is wrong perspective as the lens for helping individuals. As we identified earlier, all of us have resiliency reservoirs. Helping trauma impacted individuals see their strengths and empowering them to be active participants in their healing process is really aligned with a trauma-informed focus and is integral in driving successful outcomes. So really, finding ways to highlight and normalize the trauma experience for clients in a way that is going to promote their own ability to access those resiliency reservoirs is key. All right, so if we've set the stage for that individual work, how do we actually want to deliver it? Well, as you can see on the screen, trauma-focused psychotherapies are the most highly recommended treatment for PTSD. And these are kind of the three long-standing evidence-based treatments, all of which involve some form of exposure to the memory or the traumatic event. First, prolonged exposure therapy, referred to frequently as PE or PET. As Susan noted at the outset, I am certified in this modality. It's a very manualized protocol, which involves significant exposure both in and out of session. Generally speaking, completion of a course of PE is going to be somewhere between 10 to 12 sessions. And so a consideration here is the duration and intensity can lead to treatment dropout for some clients. And so that's important to consider. EMDR, eye movement desensitization and reprocessing, is what I would suspect is probably the most household name or most common of these three that's recognizable to folks. The utilization of eye movements to support emotional reprocessing and for some of that exposure is the foundational piece to this as an evidence-based modality. Again, time frame for successful course of therapy can be a barrier for some clients to stick with this. The third, cognitive processing therapy, also sometimes referred to as CPT, is highly manualized as well, giving clients the opportunity to do a lot of writing regarding their trauma experience, identifying stuck points, so getting really at those negative cognitions in a specific way. CPT is notable in that it is the only one of the current evidence-based modalities that is deliverable in both a small group as well as an individual format. So, when we think about the CPT group, that is going to be a fairly small group, but you can still enjoy those economies of scale in being able to deliver it to multiple clients with one therapist. All of these modalities require training and certification and must be delivered specifically by a mental health professional. The other modality that has achieved evidence-based status is accelerated resolution therapy. I am also certified in this and highlighted here today because of some of the specific differences from the core three. This is also an eye movement based modality that's very clinician friendly and focuses on client empowerment. It was developed by a former EMDR clinician named Lanny Rosenzweig. Accelerated resolution therapy provides the client with scripted guidance for what's called memory reconsolidation, as well as emotional reprocessing. But the client is able to do that without having to divulge or verbalize their trauma experience if they choose not to do so. I find that this format is really protective against therapy dropouts, and as you can see on the screen, that the course of therapy is significantly less than the other evidence-based modalities. Whilst full certification in the 3 levels of accelerated resolution therapy also require clinical licensure, I should note that there is a modified protocol highlighted there on the right called Sensation Awareness Focus Technique, or SAFETY, and that this can be learned by any non-mental health professional, paraprofessional, even parents. It's developed to manage negative sensation, and it's a really useful tool in enhancing the trauma-informed environment. So, for example, this is a training that we have provided at our agency to all of our admission staff, to all of our CD techs, and it has given them a really useful tool to help manage some of those client challenges with negative emotion and behavior on the front end and during the course of the treatment process. So this is a topic that I am passionate about and would gladly talk about all morning if time allowed. Please do not hesitate to seek me out if you want to learn more about accelerated resolution therapy. Minnesota has kind of turned into a hotbed for training, and there's lots of opportunities. Our agency does offer some training opportunities in safety, and so that's always something I'm willing to talk about as well. Okay, wow. I feel like we've covered a lot of information and concepts in a pretty short time. I guess the brief takeaway or summary is simply that our extended experience of the COVID pandemic is currently and will continue to drive the need for co-occurring services. Understanding the additional layers of pandemic trauma and stress as a potentially new concern and an amplifier of existing conditions allows us to be strategic in conceptualizing and evolving client care while maintaining professional resiliency. These steps will drive the direction of our industry in the years ahead. Take some time to digest and consider how these concepts may apply in your care setting. Lastly, a reminder that recovery is seldom a linear path, but more often a winding road. Pandemic life will likely make that journey even more challenging. Unfortunately, data tells us that relapse rates for individuals who enter the recovery process are quite high. Studies reflect that upwards of 40% of individuals will experience a relapse or return to use within 30 days of leaving their first treatment episode, and that's even higher within that first year. But that does not mean recovery is not possible. The process can be lengthy, as highlighted on the screen, and the median number of quit attempts is 5, according to renowned researcher John Kelly. So it's our job to be patient and to ensure that the door is always open. For all of our clients, but especially those dealing with trauma, we keep that door open by keeping our mind open and making sure that we're starting with the right question. And that's a paradigm shift from where we came from in this field. Not what's wrong with you, but what happened to you. All right. We have reached the end. I'm not sure what our time frame is for questions and answers, but I will gladly do that if format allows. And then I'll just note that I've got lots of resources available, and I'm happy to share copies of this presentation if they are wanted.
Thank you, Ken. If you would stop sharing, then I think we have about 7 minutes for questions. And I have 2 questions. First of all, can we make your slides available to those? Okay, terrific. And then secondly, someone asked, does one's political views inform one's susceptibility to PTSD?
That is a fabulous and I think kind of ongoing question. It's really relevant just in terms of a lot of the anecdotal feedback that I've heard from our clinical settings, that running group on a daily basis has gotten even trickier in terms of some of this polarization and, trying to balance out the idea of course, we want to validate all of our clients in their ability to, express their views and be able to, truly feel valued as an individual, yet at the same time, recognizing that we are dealing with some hot button topics that are specifically born out of this pandemic experience. When I look at how it's being conceptualized, this is my opinion only, but that I would say that yes, to some degree, whatever those kind of ideologies may be, depending on where they fall on the spectrum, certainly might predispose one more towards anger or frustration, and so on and so forth. And it's so difficult to, sort out how much of that is like pre-existing to an individual, how much could be related to underlying trauma, how much has to do with how they're experiencing what's been going on for close to 2 years now.
Right. Okay, if anybody has a question, they can put it in the Q&A quickly. We do have just a few minutes, but Ken, you did give us a feast of information to really think about and digest. And when I listen to this presentation, the things that come up to me are we have a real need for integrative care as well. And, I'm a strong advocate of that. And, but I also see this as a workforce issue as well. And we really need to figure out how to create a better pipeline of people to come into the field and then to care for those that are feeling burned out over this period of time. Any thoughts on that?
Yeah, I mean, we could probably do another couple hours on the systemic issues in our field and all of that. I think just very briefly, really just high awareness about the wear and tear that's been going on. And I think that's, high self-awareness, because even, as managers or supervisors, if you're not in the daily fray, so to speak, that you have to understand what's going on for you, and then, what's going on for the folks who are delivering day-to-day frontline care. I think, making sure that we are being more mindful than ever about our commitment to supporting new professionals in terms of education and training, but also just, making sure they understand that they're valued and they are needed. I do some adjunct work at a couple of the schools, and, the first thing I tell every one of my students when we start class each semester is, I want you all to do extremely well here so that you can hurry up and graduate, because we need you.
Right.
Right. I know at our agency, we're very fortunate that from a leadership perspective, we made a big commitment to, the intern and practicum experience, and that we have staff dedicated to just that, and that, those have, come up to be some of our best clinicians because they've had a long-term experience with our program. I think that's something as a field that we just have to continue to embrace and evolve.